Kia ora koutou katoa, nau mai haere mai ki te Manatū Hauora. Welcome back. Thanks very much for being here for the briefing this afternoon. I'm joined today by Whapuriai Margie Apa, who you may know as the Chief Executive of Counties Manukau DHB, and she's also the lead for the Auckland Metro region for their COVID-19 vaccination program. I've also got with me here Shane Hunter, who's Deputy Director General for Data and Digital here at the Ministry of Health. He's going to make some comments about our information systems that are in place and are being built to support the rollout of the COVID-19 vaccination program, and obviously he'll be able to take any questions on that area. As we signalled in the advisory, we like to do things a bit differently today. It's an opportunity for you as the media to ask us some in-depth questions and get a real sense for the program, both where we've come from and where it's heading. I'm going to start with a bit of an overview and update, including a global update. Unfortunately, we were unable to get a sign language interpreter here today, but there will be a transcript available on the Ministry website tomorrow. We've also got a bit of a package for you to pick up on the way out, which has got our latest vaccine research insights around acceptance and hesitancy around the population, and just how that's tracking over time. So I haven't even seen that myself, but you'll be getting it at the same time as me. So that will be available for you on the way out. Just a bit of a global update with vaccination. Of 220 economies and countries around the globe, 194 have started vaccination programs. And of the 26 who haven't started, 7 have actually received vaccines and are due to start, and another 5 will be receiving vaccines in the next 5 days. And interestingly, over 733 million doses of vaccines have been administered now around the world. A total of 14 vaccines have been through a formal approval process in one or other country or jurisdiction, and countries have secured 11.2 billion doses of vaccine, and the projection is that 21 billion doses of vaccine, of one or other vaccine, will be produced this year. But we also know the global rollout of COVID-19 vaccines was never going to be straightforward, and I think we've seen this illustrated over the last few weeks with issues around both the supply of and concerns around safety with the AstraZeneca vaccine. It's one of the 4 in our portfolio, but we've of course seen the impact of that close to home with the need to pivot the approach in Australia to where their medicines advisors have said to restrict the AstraZeneca vaccine use to people aged over 50 just in recent weeks. And we've seen other jurisdictions like Denmark make changes as well. In fact, they've stopped using the AstraZeneca vaccine for them in the meantime. Likewise, and I understand the correct pronunciation is Janssen vaccine, one of the 4 we have, and there's a release that's come out today on that from MedSafe. You might have seen that they've paused approval process on that for 2 or 3 weeks while more information is made available about the pause in the vaccine program or use of the Janssen vaccine in the US and other countries at the moment. So our priority, of course, continues to remain on making sure our population has access to at least one highly effective, safe vaccine, the one we're rolling out now, but we still have the other 3 in our portfolio and are looking to make sure we have backup options. There has been some global delays in vaccine access. We've seen both the talk about and the imposition of some restrictions on exports, particularly out of Europe. That hasn't been a problem for us, and we have no indication it will be a problem for us in terms of our Pfizer vaccine. We have scheduled weekly arrivals here. We have around 420,000 doses now in our freezers, and another 80,000 doses scheduled to arrive next week, and regular drops scheduled between now and the end of June. We have less detail about the amounts that will be coming from July onwards, but we do have a strong commitment from Pfizer to make sure we get all our vaccine this year. We've been watching what other countries have been doing. Israel, we've spoken to directly and about their experience around the use of invitation systems and booking systems, and Shane will talk a little bit more about that. We've talked directly with the UK about the models they've used. And with Pfizer, they've actually used just a hospital-based model. Of course, they're also using the AstraZeneca vaccine, which has got less challenges around the logistics. The US, we've also been speaking with, and Shane can talk to that, about the use of booking systems and also making use of large-scale events. I've talked a little bit about Australia, and we obviously continue to work closely and swap information with them. And I guess another observation I would make is we talked about the 194 countries and jurisdictions that have started vaccinating. The ones that are further advanced are the ones that have got significant extent outbreaks happening, and not surprisingly, they started earlier and they did so under emergency regulations. If you think about the countries that our response is often compared with, or jurisdictions I might say, Taiwan started vaccinating on the 22nd of March when it received its first drop of vaccine earlier that month, 127,000 AstraZeneca doses. So likewise, South Korea has got AstraZeneca vaccine, but they are sourcing all their vaccine through the COVAX facility at the moment, and that has had supply issues. We also are obviously working closely with Australia, and you'll see a similar pace and pattern of rollout here as with Australia. Our progress here in New Zealand is continuing now, and just to give a sense of the scale up that's happening, last Thursday was when we had 100,000 doses administered. By the end of today, a week later, it will be 150,000 doses. So about 6 weeks to get to that first 100,000, but already another 50,000 just a week later. And you would have seen the plans the Minister spoke to yesterday from DHBs that by the end of June, there will be over 1 million doses having been administered here in New Zealand. We continue to work with our 4 vaccine suppliers and are confident in our supply of Pfizer, and that we will have options on these other vaccines as well, including when the evidence emerges for the ability to vaccinate under 16. So we're keeping a close eye on that. Margie will talk a little bit more about the Auckland region shortly, but even just around the country, in the Midland region, a new community hub opened yesterday with capacity to vaccinate 500 people a day. Bay Park in Tauranga has been secured as a large-scale vaccination site as well, able to vaccinate 1,000 people a day. So DHBs really are scaling up their efforts. NZDF, the Defence Force, is halfway through their second doses of vaccinations, with nearly all their workers having received the first dose, and will have completed their workforce by the end of this month with the 2 doses. There are specific efforts around equity to ensure that our Māori and Pacifica populations have good access right from the start, and Margie will talk a bit about how that's working in the northern region. And we've got really strong systems in place for ongoing monitoring of safety. And Shane will refer to the system we put in place right at the start to monitor for adverse events. And finally, just a reflection on our effort here inside the ministry. There are over 200 people now in the ministry working on this program, and of course, dedicated teams across all the district health boards. We have Ministry of Health and wider health sector staff, and there are people from right across the public sector contributing to the effort, from Internal Affairs, MSD, Defence, Waka Kotahi, MB, WorkSafe NZ, Stats NZ and Inland Revenue, and people from the private sector here as well. I did say finally, but I just want to comment on general practice because there's been a lot of interest in the role that general practice will play. When we first set up the program, because of the nature of the Pfizer vaccine, we focused on general practice hubs because of the logistics around the distribution of this vaccine. With the ability now to use the -20 degree storage for up to 2 weeks, we are now looking at adding in wider, more dispersed use of general practice, and that planning for that is underway. There are 3 things that we need to make sure are in place. First, the logistics to be able to distribute the vaccine. Second, that the training is in place and the workforce is in place in general practice to do that. And some practices may just not have the physical capacity to do that, just as not every general practice has been able to do the nasopharyngeal swabbing for COVID over the last year. And the third thing is making sure that the information systems were in place, in particular integration between their patient management systems and the COVID-19 immunisation register. So we're working with general practice at the moment, and I had a teleconference, a regular Zoom meeting actually on Tuesday morning with general practice leaders where we discussed this. I spoke to Sam Mertens, chair of the college, today about how we develop up the protocols for using a more dispersed model in general practice, and that will take some weeks to get tested and in place, but it will be particularly important as we roll out to older people and people with pre-existing conditions who have a strong connection with general practice. So I'll hand over to Margie to talk just a little bit more about the Northern Region rollout.
Sure, thank you, Ashley. Kia ora koutou. All district health boards are in the throes of planning, setting up sites, engaging with providers to scale up our efforts. And I'll talk a bit more about the Northern Region and the approaches we've taken. Our goals are to make it set up enough points where our communities can access vaccination, those who want it, and make it as easy as possible for them to get it in a safe environment and as close to home as we can possibly make it. In the Auckland region, if I take that as an example, we work very closely together as a Northern region that picks up the 3 Metro Auckland DHBs and Northland. And it's important that we work together, and you will see this collaboration in different ways across the country, because we all want to be able to make the best use of all of our available workforce. If I take one of the sites in Highbrook, it's the first super vaccination site we set up on the 8th of March. It employs about 55 to 60 people, and we have drawn on workforces from across not just Auckland counties and Waitemata DHBs, but also involving our local whānau order providers, and they're all working together there as a team. They're scaling up to aiming to be able to do 1,000 a day, and we're at about 800 a day now. So by the end of April, the Northern region aims to have at least 22 to 23 sites open to our community. That includes 16 large primary care settings, 2 super vaccination sites that can do up to 1,000 people a day, and local vaccination sites that can do between 300 to 500 that are aiming to be located in settings that are accessible. And if I take a couple of our first ones that we opened last week as an example, in Otara, we were pleased to open a Pacific provider-led collaboration targeted at Pacific communities in the middle of Otara opened up, and they are now doing about 250 vaccinations a day. And Manarewa Marae, which is a fantastic environment. The Marae is a really important part of the Manarewa community. They offer not just healthcare, but lots of social services and community programs, and they have been able now to set up a local vaccination site for that community. And on that first day, they were able to vaccinate as part of a test run Kaumātua and Kuia from the local community as part of their site. So we are working on scaling up. We are working to plan, and we've worked quite closely with the ministry to make sure that we are able to offer certainty on what scaling up looks like for us as a city, so that we are well prepared when we open to our general population from July onwards, that we are able to offer certainty that people will be able to get their appointments done when they book. I'd also just like to comment on primary care. We've been doing a very lots of engagement with primary care at a local regional level. Earlier this week, we had a Zoom with almost over 200 primary care colleagues to talk them through and get their ideas on our plans for the city. Our ideal is that we would like general practice to be a really important player, but I think when we can work through some of those logistic challenges, we certainly look forward to having more primary care engagement available to again support our community. These are huge logistical exercises. If I take setting up a vaccination site, we had about 3 or 4 weeks before we opened Highbrook, and I want to pay some credit to the teams who are doing the back office work, finding sites that can take the kinds of volume of people that we want to take, is also able to provide the kinds of spaces where we can offer clinical teams, being able to provide good supervision, parking, which is a premium in places like Auckland, and offer an experience for people going through those sites is really important to us. And so we take a lot of care and working with our providers and communities to find the right sites that can handle the logistics, cope with the volume of people, but also be safe and accessible to communities and those surrounding sites. And so we've been really, really pleased to be able to have the kind of collaboration across providers to help us staff those sites. But we are also recruiting. You will have seen that the Northern Region, and I'm sure other district health boards as well, are out there recruiting for staff. Anyone in our community who wants to be supported to train and join our more than 1,200 vaccinators. In the last 2 weeks, we've got 250 applications, so we're really pleased to see great interest from our community. We want to grow that workforce so that we are able to sustain these vaccination sites over the coming months, however long it takes to get our community involved.
Thanks, Margie. Shane.
Yeah, kia ora koutou, everybody. I thought I'd start by a brief overview of what we've done around technology. So, and then explain a little bit about why we're doing the national booking system now, as opposed to, I guess, the questions that are asked as to why we don't have one in place. So we focused primarily initially on our COVID immunisation register. So that was in place from December last year. We were given a challenge last year when we had indications that a vaccine was coming to have a vaccine register in place by December. And we've iterated or improve that vaccine register as we have done with the contact tracing app and our national contact tracing since then. The next thing for us was inventory management and distribution or logistics support. So we've had that system in place since February, and we've been iterating since then on that. The third thing that we focused on was around what I call vaccine safety monitoring, which is really working with an organisation that existed in the health system already, which is the Centre of Adverse Reactions Monitoring in Dunedin, but really strengthening those systems so that they could scale if we were to have significant, not that we're expecting them, but significant numbers of adverse reactions. So a lot of that's been focusing on digitising and modernising the platform that they had in place. And then the fourth thing that we've been working on is our national booking system. The reason that we've left that till last is because the focus initially was on cohorts of people that were able to be managed using local booking systems through the DHBs and other organisations. And so now we put our attention to the national booking system. That will be in place by the end of May. We are starting to work with a North Island and South Island DHB on co-designing that in terms of making sure that it's operationally sound so that we can actually then roll that out across the country. So that's a end of May target date for a national booking system. The national booking system's role is to allow people to pre-register and then to actually allow them to book an appointment that suits their time. That system allows you to book for your first and second dose, and it allows you to actually have your second dose in a different location to your first dose if it doesn't work for you to go back to the same location. So as Margie mentioned before, we're trying to make it easy for people to have access to vaccination. So that's an important part of that. The COVID immunisation register is really the single most important source of truth of who's been vaccinated, where they've been vaccinated, when they've been vaccinated, what dose that they've had, what batch they've had. So if we ever had to do anything like a recall, then that's the place where we know all the information about who's been registered, who's been vaccinated, sorry. The booking system is simply an add-on to our COVID immunisation register. So just really, the other thing I guess I'd like to make the point on is this is of significant scale. I mean, we did a lot of work around the national contact tracing system pretty quickly last year. And as you may have heard Ashley mention, we've iterated that or improved that system 21 times. That's the modern way of doing it. This whole program is at a scale much bigger than we anticipated, and certainly larger than what we had to do last year. And I'd like to pay credit to the people that have actually been working on those systems relentlessly since last year, to be frank, and good support and good co-working with our district health boards, primary care, vendor community. So yeah, I'll leave it at that, and I can take questions when people need them.
Thanks, Shane. Let's open it up for questions, please.
Just on the booking system, you said that you're wanting it sorted by the end of May, but that sort of coincides with Group 3. So are you going to have enough time, I suppose, to sort of make sure you fix any bugs in the system before it's open to a much larger cohort population?
Yes, so we're by end of May, we anticipate that if there are any bugs or anything to be sorted out, it'll be sorted out ready for that. So it's going in place in anticipation of ramping up and then being absolutely ready for scale.
Can I just ask as well for an update on the change of regulations for those non-regulated vaccinators? Can you perhaps outline what exactly needs to happen in that space, perhaps some timeframes around that as well?
Yeah, so team's working very hard on this, and we know the district health boards, particularly in the Northern Region, are very keen to have access to that workforce. There are a couple of things that need to be done. One is changing the regulations. So at the moment, only registered practitioners and a whole range of those are able to be accredited vaccinators. And in fact, the Director of Public Health, Dr. Caroline McElnay, has increased the number of, approved the number of professions that can, who are registered, who can now vaccinate. So we need to change the regulations to make sure it's lawful that our this unregulated workforce is able to, under supervision, be trained and under supervision to vaccinate. So the regulatory work is happening. In parallel, they will need some additional background training rather than just doing the 2-hour, or in addition to the 2-hour Pfizer-specific manual. And so we've been developing a program up with a provider to develop up that program, make sure that they can have access to that training, additional training as well. And the aim is to, the team's working furiously, the aim is to have that all completed by the end of this month. So less than 2 weeks away. And so by the start of May, they will be able to start training and then be deployed from May onwards. Yeah. So there's a lot of interest. The other thing we just want to do is get this right again, because this is a legacy for this workforce. It means that they can have access to training and upskilling. And if we are able to change the regulations and get the training in place, then we can enable and empower that workforce to be able to do this into the future, which would be great.
With that booking system that you were talking about, how flexible is it going to be? Because let's say I book in and then get a sick kid, or I want to change location, or I'm away from work. Can you do that, and will a lot of people be able to access it and make changes all at the same time?
Well, certainly in terms of how many people will be able to use the system simultaneously, we will ensure that it's got sufficient capacity to deal with what we anticipate will be significant load. In terms of flexibility, absolutely. One of the things that we've learned from overseas is that you've got to provide people with the experience, and that is right from essentially registering, through booking, through getting the vaccination itself, and that includes the flexibility to change points, and things will pop up and the system has to deal with it, and absolutely it will.
And it will be easy to say, marry up if you cancel your first one, the second one, or vice versa.
Yes, the system will track all of that sort of stuff, yes.
Is there anything else of this scale? I mean, I just can't think of an app or a booking system where you would have to have that volume of people. I mean, have you looked at other examples?
We've spent a lot of time looking at what people have done overseas. We've had a number of conversations with people in other jurisdictions. That's been very enlightening, to be frank.
Can you give us an example?
Well, we've talked to the people in Israel, we've talked to people in the UK, we've talked to people in the US. I mean, we've got partners that have basically done a lot of, discovery work for us as well. Yeah, I mean, it's on a scale, as Ashley mentioned before, that just the sheer volume of vaccinations that have been, given so far is huge. But then, IT these days technically can scale. It comes down to people and the physical logistics in many instances that govern things. But, certainly, and that's one of the reasons that we are working very closely with our DHB colleagues, is to make sure that the system does cater for all the different circumstances that come up, because people don't always do what you think they're going to do, and we have to anticipate, but then also we have to learn, and hence we have very rapid turnaround cycles on things. So if we find that something's not right, we can generally fix that pretty quickly.
Because it would be the biggest in New Zealand, wouldn't it? I can't think of anything.
Well, I don't know, actually. I mean, if I think about Air New Zealand, for example, when they do their campaigns, that'd be pretty big.
But that would still be a fraction of the population who'd be accessing flights, though, wouldn't it?
Well, I think if you think of other things like the Electoral Commission and registering people for voting every 3 years, so we've had a really good discussion with them. They've offered to second one of their people in. They've also got access to 25,000 people who are happy to support, the 3 weeks of work around an election every 3 years. So they're going to provide us with access to that group of people, so we can enrol them. And there will be opportunities, and this is a bit of a plug, if people want to help or want to know what they can do. I guess the first thing is inform yourselves about the vaccine and encourage others. The second is have a look at when to expect that your opportunity will arise. And I should say, you won't have to have booked in to have a vaccine at the time. Once we open it up to the wider population, there will be plenty of provision for walk-in. But the third thing is that once we scale up to those, and DHBs are doing those large-scale events, we will need volunteers to help there, and so there will be an opportunity, and we will make sure there is a way that people can register their interest.
Do you think that you're communicating with GPs potentially too late? You know, there are a number of GPs who aren't sure now if they're, willing to participate in the rollout of the vaccine because they say there just hasn't been clear information around what the expectations are for GPs. What do you say to them?
Well, I think just to go to the point, if there are GPs to say they don't want to be involved, I get an overwhelming sense that general practice does want to be involved. We have been talking and working with general practice leaders, and Margie talked about the work that's happened in the Northern region to date. One of the things I would say is that what GPs have been asking for is certainty about how they will be involved and when. And so my team has worked on a communication that's going out from me in the next day or two to say, here is how general practice is involved at the moment. And, for example, through delivery through general practice hubs, here's how we will involve, here's how general practice is engaged in designing the next stage. And in a month's time, this is what we anticipate general practice's role will be. And then in 6 months' time, as we move into the sort of the business as usual long-term arrangements for the program, this is what general practice will like. I think what they've been asking for is just more certainty and clarity around what their role will be. And I dare say that has been evolving. So the ability to use a more distributed model of general practice has only really come on the table in the last couple of weeks. And so we're now working on that.
So
I would just encourage general practitioners to also talk to their member organisations. Primary healthcare organisations have been discussing with DHBs at both a national and a regional or local level how we can work together and plan. And as these really important variables become clearer in our planning, we can be more firmer, including funding models and how we work with larger groups of practices. So I'd certainly encourage general practitioners to talk to their primary healthcare organisation or their membership organisation who has been involved.
So what date, for a clinic in South Auckland and Manuela, for example, what date could they expect to have the vaccine and be able to vaccinate their patients?
Well, I think Margie mentioned you've got 16
We've got
general
16
practice hubs
primary care
coming online.
hubs, and we're just in the last stages of confirming the contracts and the funding models to be able to support them. Other DHBs will have similar models. Certainly, I think Capital Coast has already started because a lot of their community sites are actually delivered by primary care organisations. So it will vary around the country.
On the booking system, sort of you talked about the volume and capacity of people using the booking system. What are you working towards there? Is that sort of, are you expecting thousands to be on the system at the same time, tens of thousands? What sort of the capacity there?
But look, I don't know the answer to that. What I can tell you is the platforms that we use can scale pretty quickly to deal with volume. We're anticipating thousands of people wanting to access the system potentially at any one time. We're working with our partners to make sure that it can handle load. We'll absolutely be, on the conservative side, so we'll allow for pretty significant volumes.
And so you're confident that sort of it won't be sort of 1st of July or beginning of July, beginning of the public rollout, thousands will stream to the website and it will crash.
I'm very confident in our partners' ability to deal with the sort of volumes that we're anticipating that we'll get. Yes.
Is the data going to be kept onshore, and will the service, be run onshore, or are you using offshore services like Amazon Web Services?
We're using the same, it's all based around the same platform that we've had since contact tracing and our bowel screening, which is cloud-based Australian located data.
Can I just ask what IT systems you're going to be using to keep track of vaccine stocks? That was one of the systems I mentioned was our inventory or distribution inventory management system. So we have a system that deals with, once the product arrives in the country, it gets recorded in that system, and then where it goes, that's all recorded in the system and tracked. So if we needed to, for example, recall something back for whatever reason, then we will know where it's gone and where we need to get it from, if it's been administered, then we would know too. So essentially those systems link up.
New Zealand, a lot of New Zealanders live in quite rural areas, obviously, and I don't think most people in Auckland and Christchurch will find it pretty easy to go get a vaccine somewhere. Presumably you're going to have the vaccine every general practitioner in the country, all going to have the infrastructure to be able to handle it. What's kind of really like the maximum that a Kiwi would have to drive, say, to get the vaccine? How distributed are you going to be in places like the West Coast, there's quite a few people who are quite far away from the hospital.
Yeah, look, what I could say is that DHBs have already started actually delivering that. So I think about Southern DHB, they've started already out in some of their more remote communities. I would say for people that they should expect it will be where they would normally access healthcare services and or at a local community sort of setup. So part of the model is, and one of the models that we've developed is that sort of mobile team to go out and set up a bit like they've done for swabbing when we've needed to scale up swabbing around the country. Then we've had teams go out into often quite remote and rural areas, onto marae, town halls, schools, and so it'll be the same approach.
Do you expect those will be the last people to get vaccinated? The long tail, the end of December will be these people?
We discussed this morning as a group with the chief executives we had an hour discussing the vaccination program, and this was, Marge, you might want to fret, but we're adamant that that's not going to be this long tail actually, that is done right from early on as well, not just as a later.
I mean, it's one of the menu of options that we want to make available. So we've got a lot of experience of setting up pop-up mobile testing units, and it's a completely different service, but the similar concept. And we would want to focus those units at populations that we might not normally get in easily, but we want to get them in rural areas. I mean, Counties has a rural area in Pukekohe. If you go down to Port Waikato, they believe that they're pretty rural as well. So all those options DHBs are working on to make available to our communities at the right timing in the campaign.
Sorry, just following up on that, is that part of just tying and going out to those rural areas with the fact that the balance of the vaccines only comes later in the year, so while you've got smaller numbers, you can go out and sort of knock off those communities and tick them off for the bulk that kind of comes out later on. Is that part of that too? Yeah,
so the comment I would make is the sequencing framework, which is pretty broad about the groups and the prioritisation of the vaccine, particularly to the end of June, as you've said, when the supply is relatively constrained. But they're not sharp lines between the groups. And so, in fact, this is exactly what we discussed this morning. If Southern is taking a mobile vaccination clinic out into a rural setting to get the older people, and it's quite a small place, then it would make sense for them to do as many people as possible while they're there, even if according to the sequencing framework, they may not be able to start till July. So I think one of the things I would say is you will see DHBs using these models right from early on, not just waiting until after they have done the bulk of them.
Dr. Duncan, can you just run us back, re-familiarise us with a few of the headline figures? So once this really scales up and gets going, how many vaccinators do we want to have? Like, how many is there an idea of how many super clinics that sort of need to be around the country? Just run us back through some of those numbers.
Yeah, so I'll make two comments there, and the numbers that I sort of have got in my head. The first is that we're in this first scale up now, and that is moving from a few thousand doses a day up to between 12 and 15,000 doses a day, and that's the trajectory we're on now. Then it sort of levels off as we go through to the end of June. The next step is up to sort of 50 to 60,000 a day as the vaccine supplies come in. The second comment I would make is that, as we found if you look at the testing when we've had outbreaks in Auckland, for example, there's a lot of focus on the pop-up and the big community testing centres, but still between 60 and 70% of the tests done every day were done through general practice and urgent care. And we will see the same. And I think this is the point general practice is making. If you think about childhood immunisation, 80 to 85% of childhood immunisations are done routinely through general practice. There are then additional efforts put in to get the other groups in the population who might not be captured by general practice. So I think my sense is that as we go into that large scale up, a lot of the bulk of the vaccination will still be done through general practice, other primary care settings, the community clinics that are being set up to do, say, 1,000 a day. But then there will also be, I think, some larger scale events that each DHB, depending on its size, will want to run, and they may be the sort of 10 to 20,000 people in a day.
But can I just reinforce that all DHBs are really committed to taking an equity approach to access. So we're not going to wait for the groups that would traditionally, we might find, sometime into the campaign haven't access to vaccination, Māori, Pacific, older people, people from communities who may not speak English as or speak English as a second language. Our aim is to make those options available and get access for those communities earlier in our campaigns, and that's certainly the way that we're planning to set up. So, and particularly for rural communities out there, certainly I know those district health boards who have large rural populations, they are very much have at the forefront of their minds making it really accessible for those communities early in their campaigns rather than waiting.
Dr. Lindberg, you mentioned earlier that you were looking to recruit volunteers. Can you explain what sort of roles they're doing and when they come into the picture?
So that not at the moment, but it's a nod towards the future, particularly when we're doing these large scale events. So you can imagine trying to do 10 or 20,000 people a day in Eden Park. You would want volunteers to do those roles around, in the parking, the sort of pointing people in the right direction, helping with taking details and so on.
They won't be doing any sort of health roles.
No, we've got our vaccination teams who'll be focused on
In
that.
terms of the sequencing framework, I was just wondering, yesterday we got the data from the DHBs and we're expecting to deliver by the end of June, which is about 1 million doses. How is it going to work at that point? Because that would imply that most of Group 3 wouldn't have gotten doses, because 1 and 2 need about 1 million doses, right? So how does the framework work once you open it up for Group 4 and most of Group 3 hasn't been done? Do you allow the bookings for Group 3 first before you get to Group 4, or? I understand it's not hard and fast, but how do you juggle those two?
So the two things there. The sequencing framework, of course, is about when those groups start. I think you asked the question yesterday, and so we're not expecting, of course, and we won't have the vaccine to do all of Group 3 by the time July rolls around, but it starts through June, through the middle of May, and on it goes. But DHBs, the second point is DHBs will have models of delivery that are explicitly designed to make sure they are getting those people in Group 3, because they actually absolutely want to get people over 65 and those people with pre-existing conditions. And as I've said, that's why we are looking at this more dispersed model of general practice, because you can imagine there's quite a strong connection between those groups and their general practice. They're more likely to want to go into their general practice they know with a doctor they know or a nurse they know. Whereas when you get into Group 4, and it's those of us who perhaps don't go to the doctor as frequently as others, we're more likely to just sort of find, oh, look, there's a pop-up there on the weekend, I'll just go and I'll take the newspaper and sit and wait and take my chances and get my vaccination.
Your opening statement.
Well, I was just going to say, on a day-to-day basis in a site, we may find that we get through a particular group earlier and quicker, and so we will pull those groups earlier, and that's very much dependent on where each DHB is in its campaign, but we're generally following the sequencing framework.
Just your opening statement, you mentioned that there's a bit of uncertainty in terms of Pfizer's delivery schedule post-July, which is the big ramp-up period. Can you speak a bit about that uncertainty? I know that's in the future. But.
Yeah, there's no uncertainty. We feel very confident, and I think their track record to date is very good, that they will deliver. But what we don't have is, we know to the end of June exactly how many doses are arriving each week and pretty much what day they're arriving. What we don't just have that detail yet from July, but in fact, what I can say is the Prime Minister spoke to the global head of Pfizer a few weeks ago to get an assurance about the fact that we would get all our doses by the fourth quarter, actually. So we're confident we will get the doses, we just don't have the detailed numbers yet.
So the negotiations underway right now to kind of nail that down?
It's not so much a negotiation, it's just getting the confirmation of the delivery schedules.
Dr. Linford, we've pre-ordered that Johnson & Johnson vaccine, haven't we? So what's the impact of MedSafe asking for more information about it? Does that potentially slow down the rollout of our vaccination program here?
We've got advanced purchase agreements on the Janssen vaccine, that was made by Johnson & Johnson, as well as AstraZeneca and Novavax. We have the option, though, around when we want to take delivery of that vaccine. At the moment, we have 2 million doses of the Janssen vaccine, and the indication is that they will be able to deliver that in the third quarter of this year. And so there's still time as we go through that approval process. Again, I think the fact that we're taking, in a sense, taking our time to make sure we're rolling out the program in a measured and safe way means that even with this emerging information, we are able then to take a good look at what other countries find and what they do and what their response is around this vaccine. What I would say is, though, that just the information that's come out to date around the Janssen vaccine is, again, very rare event that, of course, needs to be balanced up against what the benefits are of that vaccine. And again, just to go back to one of my early comments about uncertainty, we haven't had the same problem yet with the Pfizer vaccine. That doesn't mean that as more and more vaccinations are given around the world with really good safety monitoring, that things won't pop up. And that's why we've got our process in place. If we need to, if something comes up, we will, of course, respond to that. If it means the program needs to be paused, we will do that. So you will see us responding. But it just does go to show the nature of this program, not just here, but also around the globe, as there is a lot of uncertainty.
Follow on from what Justin was asking about the numbers. It's starting in May with Group 3, but with the numbers that you released with 1 million or so till the end of June, and given that there's basically 500,000 people in Group 1 and 2, if I'm in Group 3, should I realistically expect my first jab at the start of May?
People will start to get invited if in Group 3, they will start to get invited as per the schedule. And as I say, there will be some overlap between them. So some people there are sort of three groups of people. There are those who are chomping at the bit the very first day to get their vaccine. Then there are those who are ready to go, they want to have it, and they will make a booking, and maybe a few weeks down the track.
At the start of May, we wouldn't be, thoroughly through Group 1 and 2 if we're starting with Group 3, given the numbers that you released.
Yeah, and each DHB will have a plan about how they make sure that they are getting right through, and that people from Group 1 and 2 have got every opportunity to have the vaccine as it then rolls into Group 3. So
if I take an example, in Otara and Manereo Marae, we have started to vaccinate very small groups of people from Group 3, kuia kaumātua from the community, partly to help us test the flow of the process, but also to start getting out to our communities that their own local kaumātua kuia elders are actually getting into the program, and to start building up the confidence of our community to come in. So each DHB will take a tailored approach depending on their local population demographic and the sites and where they're located.
Dr. Boone, I have a numbers question as well, surprisingly. If you deliver 1.2 million doses through June, which is on the sort of current DHB plan, and you then have 7.2 million doses for the rest of the year, that means from July 1 to December 31, you have to deliver about 280,000 doses a week. Is that realistic? Will the system be able to do that on average?
That is definitely the plan. So at the moment, we're doing that first scale up, and then the next plans you will see coming from DHB. So there's no rest for them. They've just got the plans in around to the end of June, and now the planning continues. And in fact, this is what a lot of the work around the booking system is to support this, is that next scale up. It is a mammoth effort, and it will require not just the approaches and places we've got in place now, but that wider use of general practice, possibly other places like pharmacy we still have to look at, but also though it goes up to a whole new scale. Yes.
And you're still confident that we can deliver more than 1 million vaccines a month, and that everyone who wants a vaccine will be able to get it by the end of the year?
That is absolutely the plan, and I'm really confident that a health system will be able to deliver that day in, day out. They deliver an enormous amount of care, and last year we vaccinated more people in the space of a couple of short months, more people with the flu vaccine than had happened in any prior year, and that was in the middle of a pandemic. So, the health system has got amazing ability to deliver these sorts of programs.
Who's actually building it, and when did they start?
We're working with Essentia. Essentia is who we're working with to configure the system. I can't tell you the exact date that they started, but it would be in the last probably 6 weeks.
What makes you confident that you're going to be able to build a system that's robust on such a short build time?
Well, the way I would describe it is configuring a system that's being used elsewhere. So it's not a build from scratch scenario. If we were building from scratch, yes, we would be struggling, but we're effectively using our configurable booking platform that integrates in with our core CIO.
And so you're using that in other parts of the health system, or it's in use in other countries?
It's used in other countries, but not here in New
Is
Zealand.
this part of the national immunisation solution, or is this a short-term gap before we move to the Deloitte Salesforce?
No, this, I guess the Salesforce platform is the CIR. That is, so we're extending what we've been using. So this is a plug-in to that platform. Is it part of the national immunisation solution? We'll have to wait and see. I think at the moment we need to focus purely on what we've got on hand, which is the COVID-19 vaccination program. It could become part of the future solution. It may not.
We are taking a legacy approach though here, and we've seen this with the national contact tracing solution, where now our public health units are saying, can you extend that to be the contact tracing system for all communicable diseases? So I mean, that is very much part of the thinking. The CIR is absolutely the future core of the future national immunisation system solution.
Does the appointment of Accenture, does that go through a normal procurement system, or does that have to go through
Well, it's been through a procurement process, yes.
the normal procurement process?
It's been through the procurement process, yes.
The normal one, or the one where?
Well,
where you get
it's normal in the circumstances. It's been through procurement, yes. So we've had it independently managed through procurement process.
Go through an RFP or anything like that?
It went through a closed tendering process.
On the GP, like obviously, rightly or wrongly, a lot of people feel like they pay when they go to the GP. Every other time they go to the GP, they pay, even if it's for a consult that kind of goes alongside vaccination. Obviously, you don't have control to a level of GPs, but would you be pretty upset if you heard about GPs charging in any way for this visit?
Yeah, and I would be, and I don't expect to be upset, because general practice knows very well, and in fact part of the negotiation that has been ongoing is just finalised and getting approved in the next day or two of the price that will be paid to general practice for being part of the program for delivering vaccination, takes into account the extra work that we know is required for this vaccine as opposed to other vaccines. And when people go for a currently publicly funded vaccine, usually it's childhood vaccination, there is no charge there. And there is a fee already agreed with primary care that covers every part of that visit.
Did you consider using pharmacies more to deliver vaccine? And if so, why not go in as a major part?
It's still an option, but it's not one we're actively working on. We think general practice is the first priority. We might look at pharmacy. And one of the reasons for that is also a reminder that we have other vaccination programs in full swing as well. The flu vaccination program started today, so general practice and pharmacy are actually yesterday are key to delivering flu vaccine over this next period of time alongside COVID. We've still got our catch-up campaign on MMR, which is underway, and there's still also the base childhood vaccination
You
program.
basically want to leave the capacity in pharmacies to do all the other stuff that's not.
For this point in time, and also focusing on just I guess I've talked about this as crawl, walk, run. So at the moment, I think we're moving from the crawl to the walk, and we're expecting every type of site or provider you bring on is a whole new design process, and every site that comes on goes through a safety accreditation process. So again, our approach is making sure it's measured, it's safe, and we're just stepping our way into this in a thoughtful way.
And of course, not all pharmacies are set up to manage the flow that we want to see happen, from consenting processes being undertaken rigorously through to the vaccination and the recovery time. So, anyone who's been into a retail pharmacy particularly will know it's not well set up for that process. Some might be.
You talk a bit about all your vaccine programs to run on level 4 at the same kind of throughput they plan to.
That would be a challenge. We're certainly, but we're not. We have contingency planning in place, but we're not planning to be doing this in level 4. And I think this is the other parallel task and key the key task for healthcare and the wider public service is to keep the virus out of the country. And so we can. We're in a privileged position, hard one, day in, day out, to make sure we are in elite level 1 we plan to stay.
Would that contingency speed up a lot? If you're in level 4, would you be able to speed up the stage of the other cities and stuff?
Yeah, we would. Well, we wouldn't be using an under did you say an over 70s?
Yeah,
yes, yeah.
70s,
So what we have done contingency planning for is what's a more likely scenario in New Zealand is we have an outbreak, and so we've had advice on it, are doing contingency planning for ring vaccination if we get an outbreak in a community. then we would deploy the vaccine differently to help ring vaccinate in that particular
So
location.
there's an outbreak in Nelson, and you say everyone in Nelson get a vaccine.
Yeah, that's right. We would speed up, and we would use DHB and other staff from around the country to help scale up the vaccination at a point in time in that setting. Yep.
Instead of moving piece, but is there an overall holiday on the cost to New Zealand's vaccine rollout? What is the budget like?
Well,
Keep expanding.
yes, of course, at the moment it does, but I think everyone would agree that it's a good investment at this point in time, given the nature of the pandemic. Look, I think the initial envelope for that was set aside for the vaccine advance purchases was up to $1 billion. Not all of that has been used, but I would imagine that the cost of all the rollout right across the country will be probably half that again, and over time we'll be able to.
We should expect this to cost around $1.5 billion.
Yeah, I would have thought that that's well. We haven't spent all of that billion on the vaccines, and of course, we may not spend it all in this year because we may be able to defer our options on some of those vaccines, and we've got advice being developed about how we manage the whole vaccine portfolio. But it's hundreds of millions of dollars, somewhere between $1 and $2 billion. I would have thought will be the total cost of the vaccination program.
Just on what's going to GPs over the next couple of days, can you just elaborate on exactly what that looks like? Is that sort of a letter of expectation of sorts? Or?
Yeah, well, a letter of the expectations that they can have on us. So it's giving them certainty. No, this is more a communication out to say, look, here's where we are, and just wanting to set out really clearly, this is how general practice is currently involved. This is what we are working towards for a month to 6 weeks' time. And then this is what we're anticipating the role for general practice will be later in the year as we get right through the program and out the other side, and just confirming around who the key liaison person will be in the team here in the ministry, how we are engaging with the college and PHOs on an ongoing basis, and confirmation around the payment being agreed as well. So we're hoping to improve that information.
And you expect that sort of tomorrow, or Thursday, tomorrow, Friday, the end of the week?
Before the end of the week, yes, definitely. Yes.
Real purchase agreements with the various vaccines allow us to say if Pfizer tweaks the vaccine to account for the South African or different variants, that we can get the newer kind, or that we're not stuck with the old one.
Exactly. So hence there is flexibility, or we've got good relationships with all four. I'd have to say our teams have done an excellent job, and part of that is making sure we have got flexibility. If we don't need, for example, all the doses of one or more of these vaccines this year, and of course the evidence is emerging about the role of new variants and the response, the effectiveness of different vaccines against those variants, then obviously if Pfizer or AstraZeneca or another one is tweaking their vaccine to take that into account, then our approach would be to defer out the delivery of that vaccine if we needed to use it till it was had those changes made. Yeah.
Just on the immunisation register, who's been using it to date and what have they been using it for specifically?
Well, it's been used everywhere the vaccine has been given. Is the new COVID-19 immunisation register is being used. And at the moment, it communicates in one direction with general practice. So it provides information to general practice if a patient who's registered with a GP is vaccinated. Part of that, enabling general practice to be more involved, is making sure it works the other way as well. So, did you want to comment?
Yeah, so anyone that's been vaccinated to date is recorded in that system. And we have a connection to general practice, as Ashley mentions, which just says your patient, who's enrolled in your practice has been vaccinated. I've had, spoken to GPs. It's, it's been very helpful to know, and they're comforted by the fact that they do know that their patients are being vaccinated. So, yeah.
So can employers, for example, be able to access that to see if workers have been immunised, who can see who hasn't been immunised?
So we are at the moment we have a different database, if you like, for the border workers, and we're putting a connection into that system from the CIR so that they will know which of their workers have been vaccinated. So yeah, we don't provide them with direct access to the CIR. We provide them access to the information that they provide us.
Will individuals have access to the
So
Will individuals have access to their own records in the CIR?
That is the intent, absolutely, yes. So that, we're working on that at the moment. We would expect to have that out in around about the June timeframe. We call it the consumer channel, so the expectation is that people will be able to access their vaccination details.
But it's private health information, so no employers won't be able to access it.
that's important.
Only health providers or individuals, their actual record.
What way will people be able to prove that they had the vaccine? Is there something kind of way to have a vaccine passport card very loaded to some kind of card?
At the moment, it's a card they're given to record their vaccination, and my understanding is that's pretty much what every country is doing. I was reading in the US about, and so I encourage people, once you've got your card, photograph it as well, both sides, I imagine. I haven't seen one. So you've got a digital record of it. I think, Shane, we're looking at seeing if we can add that functionality to the NZ COVID Tracer app as an option as well.
So I had a look at that today. So all that'll happen is if you have the NZ COVID Tracer app, you'll be able to, essentially have a look at your record, and you'll have to, have created a login and effectively be authenticated. But yes, that's one way.
I would have just like you in NHI. Because your NHI can already get to them.
Yeah, so it's all everything is ultimately linked to your NHI. That's right. Yeah.
Is there a plan to expand the border worker database beyond MIQ to have all of the border workers?
Yes, it already is. So at the moment, it is available to all employers all more than 500, I gather, who employ people deployed at the border. That has always been the case. They have to provide the data to populate the register, and of course, from the 27th, it's compulsory for them to use that register.
Will the CIR be used in the future for other vaccination campaigns with citizens relating to COVID-19?
Yes, so the CIR is essentially the beginning of the creation of our national immunisation solutions, we call it. So it is essentially we were already embarking on a national immunisation solution, and essentially we opted to use as Ashley mentioned before, we want to leave a legacy where we can. If we've made an investment in something to support COVID, then is it something that we can extend to broader use in the health system? Because we...
So just to be clear, the CIR will live on. The centre is building the booking system. I'm not sure what the value of that contract is. What are we spending $38 million on with Salesforce and AWS? It's not very much left out.
Oh, look, I won't get into the details, but what I can say is we're not spending $38 million on Salesforce and AWS. That $38 million encompasses a lot more than just the technology. This is a people and technology game, and I have to say, our spend on the technology versus the rest of it is very small. So I won't go into the absolute details here, but I can tell you that is not all on that technology.
Can we cheekily look at that and then ask you your impression of it before you go?
What's you mean my time?
No. The information about
the information pack. Yep. Okay. Why don't we hand that around now? And I'm happy to give you. It's like an exam. You can have 10 minutes to read your papers before we start, if you like. Margie may have other things to go and do, but. Oh yes, yes. We'll hand them out now. You can, if you want to grab one, but I'm also happy to answer any questions.
One more kind of on the side, that's probably somewhat answered, but the tolerance around the 2 weeks, obviously it's not exactly 2 weeks, but just in those.
Sorry, 3 weeks for the second dose. Yes.
How far out does it start being this effective? People must have had 2 days. I imagine it's not been a while, and they must have waited 2 weeks, so it's not going to be quite.
The key thing is at least 3 weeks. Actually. Beyond that, it doesn't really matter if it goes out. In fact, you'll have seen in the UK, they made the decision not to give people their second dose on time, so they could give more people the first dose. And they've had, I think, up to 12 weeks between doses.
Right. So that's fine.
Yeah, it's just minimum of 3 weeks. Yeah.
There's a lot of tolerance, but I don't think people come late.
Yeah, but what we encourage people to do is have it at around 3 weeks after the first dose, because that's the regime that was used during the trials and where the evidence is.
And who's providing transport for vaccines?
PACE, I think, is that went through a tender process, and so PACE is doing. Actually, there's two things. There's the distribution from the main centre in Auckland out, and that's usually overnight flights. It goes out with on, don't know who's doing that, and then yes, PACE is used to get it out to the actual vaccination sites.
On this year graph, why does it only go to 8 million doses rather than just anyone obviously the population's 5 million?
Yeah, that's the current eligible population. Actually, so the current eligible population is 3.9 million, so over 16s. So that's the difference there. But of course, our hope will be that in the next few months, there'll be evidence at least for that 12 to 15 age group, and we can add that age group into, and we've got enough of the Pfizer vaccine to do that.
The front page makes it sound like 18 to 24-year-olds are exceptionally unwilling to take the vaccine. 48% they're very up for 38% in secondary. Is that really the case that less than half of 18 to 24-year-olds are taking the vaccine?
But it says definitely take the vaccine. So this is the group who are saying, no doubt about it, as soon as I'm offered, I'll take it. Actually, that's a huge increase, which is quite remarkable.
What do you put that to that?
Confidence in our program.
Are you finding it quite hard to tell people, basically, that this did not get rushed through? That the VSA process was actually somewhat regular, as opposed to what happened in other countries? We've got this has been rushed through, and people feel like there's an uncertainty and there's a black box situation.
Yeah. So there are two concerns that come up very frequently. One is that, or not very frequently, two of the concerns people raise is that the vaccines were developed really quickly, and therefore, how do we know they're safe? To which the answer is, we put them through a really rigorous process here, and I'm very confident in that process. And the other part of the answer is actually the technology behind them, including the mRNA technology. The mRNA technology is 10 years old. It just had never been used to scale up to produce a vaccine like this one. I think the second...
It's fair to say actually the degree of global collaboration among the science community has helped us move a lot faster.
And I guess the second question people have is, we don't know what the long-term effects might be. And of course, that's a question to us. But we also do know that because the technologies behind these vaccines are ones that have, in most cases, been used for previous vaccines, we know, and we can I think we can take comfort from the fact that vaccines prove to be safe and effective over time, very safe and effective over time. And as I said in my opening comments, 733 million doses of different vaccines have now been administered around the world, and that helps New Zealanders be reassured about this.
What do you make of the sort of percentage of those likely to take a vaccine remaining steady? Like it's not going down, but it's also not going up.
Yeah, it's around 70%, I think, in all the service. That's the people who say definitely or probably would take it. You know, what I think will happen, and we've seen this around the border workforce as well, is you'll get a group, and it's about 70 to 80% who straight away do turn up, and then it just requires a bit more effort to get that next group, and we see this with childhood immunisation. But the group that is absolutely not going to have it because they fundamentally oppose it is generally quite small. I think at the moment it's about 10% of people saying definitely won't have it. I fully expect, based on previous experience, that will drop away again further.
Do you see that trend as sort of word of mouth, something as simple as that, where someone says to someone else, hey, look, it's not that bad?
It's word of mouth and people looking around and seeing what others are doing around them. We're all quite susceptible to peer pressure, which is, in this case, not a bad thing.
Do you have any more data about the 20% unlikely to have it in terms of whether they're concentrated in a particular region?
I don't...
We talk about herd immunity being good if there's like a certain threshold in a community that aren't vaccinated, then they are.
I don't have any particular regional breakdown of this, but we do know from our childhood immunisation rates and sort of refusal rates, they do vary a little bit by region, but it's probably more to do with variation in between different ethnic groups rather than regional groupings per se. I think the other important thing here is if we think about our Māori and Pacifica populations, they're quite young populations. So around a third of Māori are under 16. And so that's something for us to consider, and why we need to have absolutely high rates amongst our over 16 population to make sure we are protecting our young people and children as well.
You need to add the vaccine to other health interventions. So if there's populations who might be not keen to come in, they might come in for something else. Is it your intention to maybe say, hey, while you're here, we're going to give you a shot of COVID vaccine? Or would that be too much kind of a breach of really serious areas.
Not at all. That's how the system runs at the moment for childhood immunisations, often for screening tests as well. We call it opportunistic screening or vaccination, and I fully expect that will play a role as well. It's definitely not unethical. I think, in fact, the obligation is on practitioners to make sure people are given that opportunity if they're turning up for another service.
This chart, would you describe it as illustrative or a little bit more definite with numbers behind it?
It's illustrative and quite definite. Yeah, I mean, that's designed to, we've got certainty up to the end of June. And this is what we're projecting based on what we believe we have to deliver after June. That's the trajectory it will be on.
And the 9.4% of people who just say they definitely will not take a vaccine, and that's expected to remain stable. That's quite a bit higher, about double the size of, in my understanding, is the percentage of the population who sort of regularly refuse things like the MMR vaccine for their children.
Yes.
Why do you think there's that difference between COVID-19 vaccines on one hand and the other vaccines that we used to have on the other?
So, I mean, two comments. The first is I do think that will decline over time. First of all, I think it will get down to a much smaller percentage, and there will be different reasons for that. People might realise that if they want to travel overseas, or they've waited for a year and seen that actually everyone who's had the vaccine is fine, and what's more, they're protected and safe from the vaccine. But I think the difference is often people will act differently for their children than they do for themselves. That's the first thing. And secondly, there is probably just that that higher level of uncertainty that people think about, well, I'll just wait and see what the longer term impacts might be. And of course, we're fortunate here in New Zealand because at the moment we're safe and protected because of our border arrangements. But of course, as we want to open up the border, that will change. And then I think people's perception of the importance of vaccination may also change too.
In terms of addressing that perception of the vaccine, are you specifically doing anything around social media or speaking to social media, especially around sharing fake news and making sure that there is alternative information available for those people?
Yeah, look, there's a lot of information out there now, and from next week you will see, that start to really scale up as well. So we want to be really sure that every New Zealander is getting the right information and good quality information through a whole range of channels. So that's going to start scaling up again from next week.
Have you been speaking to like on Facebook, for example, like sharing the YouTube videos about vaccines and, sharing that false information about perhaps taking that down, those sorts of information that are being shared around groups?
We haven't been talking to Facebook, but I dare say I think social media platforms, including Facebook, are being quite responsible in this regard, is the first point I would make. And also I think the better response is for us to make sure our information is out there across all those media and saturating the market, as it were, so that people have got easy access. Maybe one more question? Or two or three. I shouldn't have said that. One more sweep of the room.
So this figure shows that 70% of people who want a vaccine say that they need more information, that they want more information. Does that number kind of surprise you that that's so high?
It doesn't. All our surveys show that people have a real thirst for information here, and that's part of the reason why we're continuing to develop, and there will be this big scale up from next week. It's just to make sure we are providing the information.
And it seems to be around adverse reactions.
Yep.
So, as an example, the MedSafe put out yesterday some new information on adverse reactions.
Yes.
And as I said, there were 3 serious adverse reactions over the last few weeks. Can you talk about that?
Yeah, I think they're now doing a weekly update, MedSafe, of the latest data on adverse reactions. And their first publication was it was 2 Wednesdays ago, and it talked about these 3 adverse reactions. So these were allergic type reactions, none of which required significant, none of which where a person required hospitalisation or had any long-term issues. So they were dealt with there and then. And one of them was actually on investigation, felt to be not related to the vaccine, but related to food.
So would that be like if you're there sitting there 20 minutes, if they got quite a bad rash or something like that? Is that sort of
Yeah, so if someone's going to have a true anaphylactic reaction with swelling of the face and so on, it happens very quickly, almost always within minutes, and that's the one that's why people wait for that 20 minutes. For some people, it's a bit delayed. That may be more, as you say, a rash or some other allergic reaction. But it's those more immediate, more significant allergic reactions that would be classified as serious, but not serious in the sense that anyone's got any long-term or lasting.
When you talk about this, the scaling up, is that those TV ads, are they sort of going to start rolling out next week, or is that sort of something else that's still to come?
It will involve TV ads and advertising through a range of other very important, equally important media.
So is that the sort of major chunk of our, the major chunk of our sort of public information campaign, that public rollout?
The public rollout, and I think, you know, it will include booklets out in people's letterboxes. It will include TV ads, radio ads, all the social media channels. It will include videos of champions, of people that New Zealanders will know, to point them towards where they can find good information. So
who are some of those champions?
You've got me there, but watch out for next week. Maybe this is a good topic for the briefing next week, in next week or two.
Do you have a figure in mind as to what will be needed to achieve sort of herd immunity in the country?
We've moved our language away to population immunity. So
Population
not yet, I think. But again, if you think about the fact that our eligible population is around 75% of New Zealand's population, we would want to be getting as many people in the eligible population vaccinated as possible, and that's absolutely our aspiration. And if you talk to I've talked to Professor Sir David Skegg, who's chairing the new committee about this, as we were briefing for him coming into the role, and he has exactly the same view. Actually, our target should be to vaccinate as many people as possible in New Zealand, to protect them as individuals, but also to protect us as a community.
But you are working towards some sort of number here, and we're like, oh, not yet, but there's talk about it. What sort of figure are you thinking about?
I honestly, as many people as possible. I mean, even when we have childhood immunisation targets, 95%, our aspiration is still to get 100% of children vaccinated, because that will protect them. And, we would aspire to get as many people as possible. And if it's 100%, well, then I'll feel like my work on earth is done. That'd be fantastic.
One of the serious reactions reported this week, was a technical term for which I've forgotten, but was a severe immune response. What characterizes that? What should you be looking out for? And is there any sort of type of person who might be predisposed towards that, like with allergic reactions?
I don't have the details of that one, but it would have been a more immediate anaphylactic type reaction, I would think. Yes, there are two groups of people who may be at increased risk. For example, the first would be people who may have had an allergic reaction to another vaccine, because they have a number of components in them, so it may be a reaction to one of the components. Their general practitioner would know that, and these are the sorts of people who would almost certainly have an EpiPen and be able to act if they'd had a serious allergic reaction before. Then there is another group, which is people who tend to have allergies, and they may be food allergies or other allergies, and they would be at an increased risk, but that's not a contraindication to them having the vaccine. Thanks very much. Really appreciate your time and presence.